So we're very pleased today to introduce Dr. Marty Kotlar, who's the president of Target Coding. He owned and operated a successful chiropractic practice for 12 years and a multi-specialty practice for 4 years. He began his consulting career with a special emphasis on CPT coding, billing, reimbursement, documentation, and compliance for chiropractic and multi-specialty facilities. Over the last 12 years, Dr. Kotler has provided valuable nationwide educational seminars and consulting to over 3,500 healthcare providers and their staff members. Dr. Kotler is certified in CPT coding, a certified professional compliance officer, and a member of the American Academy of Professional Coders. He has written 8 books on chiropractic coding, compliance, and documentation, and he's a contributing author to Chiropractic Economics Magazine and Dynamic Chiropractic. He's a featured guest speaker for Foot Levelers seminars, Parker seminars, the Coding Institute, and at many state association conventions nationwide. Please welcome Dr. Marty Kotler.
Thank you, Valerie. I want to thank you for having me today, and I want to thank everyone over at the GCA for inviting me to do these presentations. I always enjoy doing them, and I hope everyone else does. So yes, that was a very good introduction. Thank you, Valerie. So, yes, as Valerie said, I'm a chiropractor. I'm also a certified professional compliance officer, certified billing and coding specialist. So I consider myself kind of unique because most chiropractors are not certified coders, and most certified coders are not chiropractors. So you'll see during this webinar how I combine both specialties to make sure you're doing things properly, you're complying with laws and rules, and you're getting reimbursed what you deserve. So we're going to begin today. There's 2 main topics we're going to be covering: the evaluation and management coding guidelines, which had a dramatic change occur to them as of January 1st of this year. And we're also going to talk about proper modifier use. So we're going to begin with the new E&M guidelines that became effective January 1st. Let me take you down memory lane a little bit regarding the exam. We're talking about examinations and re-examinations. We're talking about your 99202, 203, 204, and your re-exams, your 213s and 214s. Little memory, go down memory lane here. It all started back in 1992. The AMA introduced E&M coding to describe E&M visits. In 1995, we got very specific on the guidelines for E&M, introduced details about the history and the exam. And then in 1997, more guidelines were introduced to specify specific single specialty exams. For example, the musculoskeletal exam. Then we go up to 2007, and CMS revalued all the E&M codes. 2018, a proposal to these codes was made. Then in 2019, the federal government introduced an initiative. It was called Patients Over Paperwork. The purpose of this was to reduce administrative burden on providers and allow you to spend more time with patients. Great. It's been working fantastic. You'll see in a few minutes. And then January 1st of this year, we have new E&M guidelines for codes 99201 through 215. Let me do a quick little review on the old guidelines. For those of you that have been to my seminars and webinars in the past, you remember I would talk about these in detail. For example, 99203, you look at the first key component. The old guidelines were based on 3 components: history, exam, and decision-making. So with 99203, which is the most commonly billed new patient code, it was approximately 30 minutes. You see in parentheses, 30. It could have been 25. It could have been 35. The history detailed. What's that? If you remember from my seminars and webinars, a detailed history for 99203 with the old guidelines meant you had to document at least 1 chief complaint, 4 HPIs for a history of present illness, 2 to 9 systems needed to be reviewed with the patient, and at least 1 item from the past family or social history. You had to document that in order to satisfy the detailed requirement for the history. Then we had the exam for the old guidelines. Detailed exam. What did that mean? That means you had to have at least 12 examination findings, 12. And then the complexity was low complexity. So that's the old guidelines. Now let's go now and talk about the new guidelines. I mean, they're not that new anymore. I don't know if you consider them new or not. We're in July now. These are, over 6 months old. These are based on two key factors: time or decision making, not and, time or decision making. So as a healthcare provider billing E&M codes, you have a decision to choose time or decision making. 99201, say goodbye. It's been deleted. As of December 31st, 2020, CPT code 99201 doesn't exist anymore. So when a brand new patient comes into your office today, regardless of what they say, let's say, well, if they mention a very, very mild condition, Mrs. Jones comes into your office with mild neck pain. She says the pain scale is a 1. Well, the lowest level E&M code you could bill as of January 1st is a 99202. Some of you take care of young kids, pediatric patients. A lot of you would use 99201, the lowest level possible new patient code for a 4-month-old. Well, you can't do that anymore. It has to be a 202. So now let's go over the two key factors. The first one is time. There are time ranges. Here's the chart for all the codes. You see 201 deleted, 202, 15 to 29 minutes. You spend less than 15 minutes, you can't use time as a key factor. 99203, 30 to 44 minutes, 99204, 45 to 59, 99205, 60 to 74. And then we have the established patient E&M codes. 99211 doesn't even have a time component attached to it. You could bill it, but there's no time component. 212, 10 minutes. I don't have to read all those. You see the time ranges. So time, it's pretty straightforward. You might be saying, well, what constitutes time? Well, speaking to the patient counts, exam counts. What is new about this? The amount of time it takes you to document the encounter, you can use that. Let's say it takes you 5 minutes after the patient leaves, and now you spend 5 minutes typing or entering the information into your EHR. You could use that time. You ever have a patient walk in with MRIs, lab work, and you spend time reviewing that? Let's say you spend 15 minutes reviewing a patient's lab work before you even say hello to them. You're at a 99202. See, 99202, 15 minutes. It's whatever face-to-face and non-face-to-face time you spend on the day of the encounter. The other key factor is decision-making. This is not as straightforward. This gets a little complicated. If you want to use decision-making to determine your new patient code to be reported or your established patient code, you need to master these 3 elements. If you're drinking coffee right now, maybe you want to take a little extra sip because this gets a little complicated. Here we go. So if you're going to use the decision-making process instead of time to determine what level new patient code or established patient code, need to know the 3 elements. Element number 1 is the amount of problems. For a 202 or 212, could be very minimal amount of problems like a little simple neck strain. Look at 203 and 213. The examples are 2 or more self-limiting problems, 1 stable chronic illness. Another example would be 1 acute uncomplicated illness. Then we move into the next column, which is the amount of data to review. For a 202 or a 212. You might not have any data. That's okay. It says minimal or none. 203, 213, the data to review. Do you have any reports to review? Do you have any MRI, CT scans? Are you going to be ordering any tests? That's where the data needs to be evaluated to determine what code to bill. Or are you going to use an independent historian? That's a new term in these new guidelines, independent historian. But what's that? And I'll give you a couple of examples. Let's say a 94-year-old new patient comes into your office with dementia that can't explain what's going on. So this patient is probably going to show up with a caregiver, an aide, maybe a child, a surrogate, a guardian, and that person is going to act as an independent historian to explain what's going on with the patient. How about the opposite? A very young child, a 4-month-old, presents with a condition and the 4-month-old can't speak. So the parent, guardian, surrogate, someone's there to explain the situation to you. That's an independent historian. So requiring an independent historian can raise the level of decision making based on the data to review. And then the last column is the risk. Minimal risk, moderate risk, low risk. What's the risk? Is it morbidity, mortality? If a patient comes in with mild neck pain, what's the risk of mortality? Is there a chance they can die from mild neck pain? No, that's not going to happen. And then, the chart gets a little bit more complicated with the higher level codes. So we have 204 and 214, and now we're getting into an example of a amount of problems would be a complicated injury and stable chronic illness. The amount of data to review gets a little bit more complicated too. And then the risks increase. Now, in order to qualify for a level of decision making, 2 out of the 3 elements must be met or exceeded. So in this example, 99203 or 213, the patient has one acute uncomplicated illness. Example would be an acute uncomplicated injury, maybe a neck sprain, neck strain. Minimal or no, let's say you didn't have any data to review and the risk is low. So this would be a 203 or 213. In medical decision making, we have all these different terms. So I'm giving you a few of them here. I'm not going to go through all of these, but it's just examples. When you read the medical decision making chart, you're going to see an example of a self-limiting or minor problem. What does that mean? It means it's a condition that's going to get better on its own. It's not going to permanently alter any type of health status. An acute uncomplicated injury, there's a couple of examples there. There's no risk of mortality with that. See at the bottom of this screen, independent historian. That's an individual like a parent, a guardian, a surrogate, a spouse, a witness who provides information on behalf of the patient. Morbidity, mortality. So I'm going to give you an example right now, 99203. It's the most commonly reported new patient CPT code. So let me show you one based on time. What are the time components? 30 to 44 minutes. So here comes Mrs. Smith. By the way, if anybody would like a copy of this, just send an email to amy@targetcoding.com, amy@targetcoding.com, and she'll send you the sample 99203. It might be a little bit small for you to see, but this is a patient that comes with low back pain and neck pain. Mary Smith, a 56-year-old female, comes into the office. She says the low back pain is an 8, the neck pain is a 6. She's giving me her pain scales. She needs to take breaks throughout the day to rest her back and neck. She said it started suddenly 7 days ago after lifting a heavy couch while rearranging her living room furniture. She's had difficulty doing simple daily tasks, such as getting in and out of bed, putting on her socks and shoes. She has difficulty sitting at her computer. So I'm chatting. I'm talking to Mary Smith. It takes me 15 minutes to chat and schmooze with her. There it is, 15 minutes, history time. And then we move on to the exam, basic exam. Mary's well-developed, well-nourished. There's tenderness in the right side erectus spinae and quadratus lumborum muscles. Range of motion is restricted. Subluxations in the thoracic and lumbar spine. Muscle hypertonicity in the latissimus dorsi and the cervical region. We have severe tenderness in the right side levator scapula. Subluxations at C1, C2, C5, C6. She's alert and oriented. We took x-rays. The exam took 10 minutes. So far, we're up to 25 minutes. Now I sit at my computer, or for those of you that are still handwriting your notes, now I'm jotting down the diagnosis, the goals, the procedures, the schedule of care. Let's say that takes 5 minutes. History 15, exam 10, documentation 5, total time 30 minutes. That's a 99203. Now, some of you may want to Bill 99203 using medical decision making. If that's the case, you don't have to spend 30 minutes. You may be able to do it in 15 or 20 minutes. So your note has to speak for itself. So for 99203, just make sure you're aware of the elements of decision making and you meet them. Put that in your notes, then you don't have to use time. The note has to speak for itself. So a lot of people say, well, Dr. Kotlar, where do you get all your information? Whenever I do my live seminars, a lot of CAs come up to me on the breaks and they go, how do you learn this stuff? What books do you use? What resources? So I'm sharing with you. These are the books I read. I spend a lot of time reading policies and procedures, the guidelines, HCPCS codes, HIPAA guidelines, the Medicare guidelines. There are national guidelines for Medicare, and then there are state-specific guidelines. In Georgia, it used to be Cahaba, now it's Palmetto. That's the Medicare Part B carrier. And then we have regular insurance companies like Aetna, Cigna, Blue Cross Blue Shield, and Ash and United. They all have guidelines on chiropractic. So these are the guidelines I read to stay up to date and give everybody good quality information. Okay, so now we're going to move on to modifier use. Okay, now, I don't know, Valerie, did you want to open it up to questions regarding E&M codes, or should I just keep going right into the modifiers?
I don't see any questions in the chat on that. So why don't you just keep going and then check with me in a little bit.
Sounds good. Okay, so the next item we're going to be discussing are the most common modifiers in chiropractic. There are a lot of them. I mean, this is my list of the most common modifiers used by chiropractors. I'm not going to have time to go through all of them. I'm going to go through the ones that are highlighted in blue, those 6. But there are many more that are used in chiropractic. There's also CCI modifiers you see in the bottom left corner. I'm going to go over those also. So modifiers, the AMA owns the copyrights to the CPT codes and the modifiers. A modifier allows a provider to let an insurance company know that the procedure has been altered. Something happened, something needs to be reported. Otherwise, we could just use the regular 5-digit CPT code or 5-digit, HCPCS code. Sometimes you need to use modifiers. They're used to add information or change the description of the service. Modifiers can be alphabetic. They could be numeric. It could be a combination of both, but they're always 2 digits. Some modifiers can cause automatic pricing changes, like 52, while others are used for information and statistical purposes only. When selecting the appropriate modifier, make sure it's valid for that date of service. Informational statistical modifiers, like the ones we're going to be going over, GP, 59, XS, 25, you could list those in any order. I typically use GP first or 59 first, but any order is typically okay. If payment modifiers are used, those need to be listed first, like 22, 26, 50, 51, 52, 53. Modifiers could be used to state that the service had a professional component, maybe a technical component. An adjunctive service was performed. A service was increased or decreased. There are modifiers to let a health plan know that the service is being done as part of a clinical trial. Modifiers could note that a bilateral procedure was performed, like the modifier 50. May be used to identify that a PTA performed the service. That's a new modifier, CQ. We're not going to get into that, but starting next year, Medicare Part B wants services being performed by PTAs to be designated with a modifier CQ, so 85% of the allowed fee is paid. A service or procedure was provided more than once. So there are many, many, many situations in which modifiers are used. Let's start with modifier 25. Modifier 25 is a significant, separately identifiable evaluation and management and service provided by the same physician on the same day. So it may be necessary to indicate that a patient's condition required a significant, separately identifiable E&M service. Example, a re-exam. Many chiropractors will do a re-exam on a patient and adjust the patient on the same day. See the example 99213 and 98941. You would need the 25 modifier. If you didn't add the 25 modifier to the 99213, most health plans will bundle the two together and only pay you for the adjustment, stating that the re-exam was part of the adjustment. Well, guess what? Some health plans, even though you use the 25 modifier, they still will say denied, the re-exam is part of the adjustment. So you want to make it very clear in your notes that the re-exam was separate and distinct. How are you going to do that? Look at the bottom of the slide. That sentence should be either the first or second sentence in your re-exam documentation. You want to let an auditor, whoever's looking at your notes, know right off the bat, right in the beginning. If you build a re-exam, your documentation should say something like this. The patient's condition today requires a significant, separately identifiable E&M service above and beyond the usual pre-service and post-service work associated with the procedure. That takes care of pretty much the mystery that an auditor or an investigator would have. If you ever get denied for 99213 and an adjustment on the same day, put together a good quality response appeal and let them know to reread your notes. And the notes say right there, the patient has a separate condition. What are examples of a significant, separately identifiable E&M service above and beyond the usual pre and post service? Now, the usual pre and post service we're referring to is the adjustment. So what is significant and separately identifiable that would require an E&M service? Well, patient comes in and says, Dr. Kotlar, I feel worse. I have an exacerbation. I was doing fine, and now I went down to tie my shoes. My back is killing me again. So we have a flare up, an exacerbation. That's a good reason to do a re-exam. Actually, you would have to, even if the patient doesn't have insurance. If a patient comes in and says, I feel worse, the standard of care in Georgia would require you to reevaluate what's going on with the patient. Another situation, patients coming in for low back pain, and then out of the clear blue sky, let's say on the 14th visit, the patient says, Doc, I have a new problem. I was playing tennis over the weekend. My shoulder is killing me. And now you reevaluate what's going on in the shoulder. That requires a significant separate E&M service. So there's a few situations that would require. Now, I've dealt with a lot of doctors that get denied for the re-exam, and the insurance company says it's part of the adjustment. Sometimes the insurance company is correct. I look at the notes and the doctor's note, it just looks like a regular visit. Make it look different. One of the best ways to make your re-exams look different to ensure payment for them is to use that sentence right there, if it's appropriate. All right, we're going to move on to modifier 5.9.
Dr.
The
Kotler,
description, yes.
can I pop in? We got two questions during that last little segment. One is, can 99201 or 99211 be used for cash paying patients?
Well, in general, if you have a cash paying patient, you don't need to use CPT codes. I know that if you have a cash patient and you need to put something into your computer system, you're probably going to want to use a CPT code. But just to clarify, if you're dealing with a cash patient, that's not going to be asking for a statement. That's not asking for a receipt. Like, there's two types of cash patients. You could have a cash patient that says, here's cash. I don't have insurance. I don't need a receipt. I don't need anything. Well, patients like that, you don't have to use CPT codes. You could put in your computer your own internal code, 12345. This is a cash patient. CPT codes, well, CPT is a language spoken between a healthcare provider and an insurance company, a third party. If you have a cash patient coming in where there's not going to be any billing at all, this patient says, I don't have insurance, I don't need a receipt, I don't need a statement, I don't need a super bill, an encounter form, here's cash, then you could put in 99201, you can put in 9920, you could put in whatever you feel is appropriate because nobody's getting those codes. Now, if you have a cash patient coming and paying you cash, and this patient says, oh, doc, can you give me a receipt? Can you give me a statement? Can you give me an invoice? Because this is a medically necessary exam. And now the patient's paying you cash. You're happy, but now the patient wants to recoup the money that they've paid you. So in that case, if the date of service is January 1st, 2021, and forward, then no, you should not use 99201. So I hope I answered the question.
Then the next question is, can you use modifier for new patient exam? For example, 99203-25.
Well, if the doctor is doing an exam, 99203, and that's it, there's nothing else that's being performed on that day, then a modifier would not be indicated. Now, let's say this doctor does a 99203 and is also going to take x-rays and do an adjustment. There it is right on your screen. Then yes, you would need to add the 25 modifier to designate that that re-exam was separate and distinct. But please understand what constitutes a separate and distinct exam. That's step one. If you think that you did it, then yes, you should be able to use the 25 and get reimbursed.
Okay. And there's one more. What if you're sending your claims to the clearinghouse with the 99213-25 and a 98941? Can this information be placed in box 19?
19, no. Box 19 of the claim form is an area that's designated for NUCC use. Now, there are some Medicare carriers that want the date of the exam or the x-rays in box 19, but I wouldn't mess around with box 19. Now, let me back up. Whoever asked that question, if your claims are getting denied and you're not sure, contact the plan. If the plan says, put the codes in box 19, then do it.
Okay, that was it for now.
Okay. So let's see. Modifier 59. Modifier 59, the definition of it is 3 words: distinct procedural service. So you could look at this as a cousin to modifier 25. So if 25 goes on only E&M codes, 59 only goes on procedure codes, not on E&M codes. So it's used to designate that a service was distinct and independent from any other service. Modifier 59 should not be appended to an E&M service. There's the example, 97140, which is manual therapy techniques, and 98940, 1, or 2 performed on the same day. In this case, according to the CCI edits, the 59 modifier would need to go on the 97140. A little bit more about the 59. Now, the 59 modifier is a very important modifier, and it gets used a lot. Sometimes it gets used incorrectly. Sometimes it gets used when it's not even necessary to use. It's one of the rare modifiers that bypass the CCI edits. So the CCI edits, this is a federal program, the National Correct Coding Initiative edits, also known as the CCI edits. The purpose of these edits is to electronically detect codes that would not normally be used together. The CCI edits created by CMS require that manual therapy, 97140, massage, 124, and neuromuscular, 112, be performed in a separate anatomic site than the adjustment. So if you do this, then you would need to put the 59 modifier on those codes to indicate that it's distinct and being performed on a separate anatomic site. Now, some of you might be shaking your head going, wow, that's ridiculous. I agree. There are many rules that I shake my head and I find ridiculous. This is one of them. I don't understand why. If Mrs. Jones comes into my office with neck pain and neck stiffness, and I want to do some myofascial release manual therapy on her neck muscles, and then I want to adjust C5 or C6, that's not okay according to the CCI edits. Ken, that's ridiculous. I don't make the rules. I just explain them. So the OIG found that the modifier 59 was being used incorrectly, and it resulted in over $50 million in overpayments. There's the OIG report link. You can go read about it. So insurance companies are very concerned that providers are using the 5-9 modifier incorrectly. How does Anthem and Blue Cross Blue Shield and Aetna, Cigna, United Healthcare, how do they know this? Well, they read the OIG reports. The OIG are, they're like the advanced scout for the regular insurance companies. So that's the 5-9 modifier. There are certain instances where the 5-9 modifier must be used, but there's not that many codes besides these three. For example, if you do a chiropractic adjustment and therapeutic exercises 97110 in the same anatomic site, there's no CCI edit on it, so you don't have to use a modifier. I'm going to show you a few examples in a few minutes. Now we're going to move on to the next modifier, modifier XS.
Okay, I'm
Now,
sorry. We did have a couple questions about that particular modifier.
Great.
Is 59 replaced by the GP?
GP has nothing to do with 59. So I'm not sure why that question is like asking, is an orange and a helicopter related? There's no connection. GP, we didn't get to, has nothing to do with a distinct procedural service. So there's no relation there.
Okay. And the other one was, do you see a need typically to use 59 modifier on 98943?
It's not typical to use modifier 5-9 on 98943. However, if whoever asked that question is billing an insurance company and getting denied, and the insurance company says, you need to put the 5-9 on the extremity adjustment and then we'll pay, then go ahead and do it. Don't do what I tell you. Don't do what the GCA tells you. When you're billing an insurance company, you do what they tell you. And if you don't like what they tell you, that's a different story. But if the insurance company says use modifier 5-9 on the extremity 98943, and that's what they want you to do in order to get the claim processed properly, I say do it.
And there was one more. Do we need to use the modifier when we use PT codes?
PT codes is a separate webinar. We can do that another time. I don't want to confuse people. Physical therapy billing done by a licensed physical therapist is very different than chiropractic billing. So, but in general, 5-9 is not used that much in physical therapy billing. If we're staying on the 5-9 modifier, it's not too often that a licensed physical therapist would need to use the 5-9 because there's not that many CCI edits on multiple physical therapy CPT codes being performed on the same visit. It's the adjustment code, the 989404142, that causes the 5-9 or the XS modifier, which is coming up next, to be utilized on certain CPT codes. As I mentioned earlier, some doctors are getting audited, and it's because they're using the 5-9 modifier on codes that don't need it, like X-rays, mechanical traction, 97110. I'm going to bring up the three codes right now. As far as chiropractic adjustments go, you would need to use the 5-9 on these codes here: 140, 112, and 114. Any other questions before we move on to the next modifier?
That was it.
All right, next is XS. Now, because of all the confusion, because of the OIG report, because of the insurance companies thinking that doctors are not using the 5-9 modifier properly, CMS added 4 subsets to the 5-9 modifier, and they're called the XESPU modifiers. XE, XP, XS, and XU. The XS, it says separate structure, separate because being performed on different sites. So there are some health plans that are denying claims. The claim comes back denied. The doctor's office was getting paid, no problem, with the 5-9 modifier, doing it properly. As I mentioned earlier, doctor does an adjustment, let's say on the neck, and does manual therapy on the lumbar region. So in that case, the 5-9 goes on the 97140 to designate that the lumbar region is separate than the cervical. Terrific. Claims are getting processed properly. Everything's going nice and smooth. And then out of the clear blue sky, the insurance company says, denied, missing modifier, incorrect modifier, wrong modifier. There's a good chance that particular health plan has substituted the 5-9 with the XS modifier. There's the example on the screen, 97140 XS. And if an adjustment was done on the same day, that's why it would be needed. Any questions on the XS?
I don't see any.
Alrighty, now we're going to get to GP. GP, what is the definition of this? GP says to an insurance company, the service was delivered under an outpatient physical therapy plan of care. What? To me, this is ridiculous. I'm a chiropractor. Why should I have to designate certain services that I do in my office as if it's a outpatient physical therapy plan of care? So my initial reaction is, that's ridiculous. My second reaction is, if this is what the health plan wants, in order for me to get the claims processed properly, I'm going to do it. Now, I know some chiropractors on state boards throughout the country that are trying to change this because they find it's unfair to use a modifier that designates a physical therapist is doing it when a chiropractor is doing it. But I'll let the state boards and the admin people fight that. Right now, the deal is with GP, according to United Healthcare, Medicare, and Anthem, the GP modifier is needed on all modalities and therapeutic procedures. To make it simple, any code that begins with 97, like mechanical traction, 97012, therapeutic exercises, 97110, manual therapy, 97140. There's one exception, unattended electrical stim is either 97014 or G0283. Those require the GP modifier for certain health plans. Beginning with dates of service on or after April 1st. I thought this was an April Fool's Day joke at first, but beginning with dates of service on or after April 1st, 2021, Anthem has updated their modifiers impacting adjudication to modifiers GP, GO, and GN. So if you're billing a health plan and everything's going along smoothly and out of the clear blue sky, they deny it, missing modifier, it could be because you do not have the GP on it. Here we go. I'm going to give you a whole bunch of examples now. Patient number 1 comes in. You do an adjustment to the cervical region. Now, this is certain United Healthcare, Anthem, and Medicare plans. Adjustment cervical, lumbar region, manual therapy, 97140. There you go, 5-9 and GP. Patient number 2, same scenario, but this is maybe an Aetna plan or a Cigna plan. Some plans don't require the GP. So it would just go out with the 5-9 or the XS. Patient number 3, adjustment to the lumbar and therapeutic exercises, 97110 to the lumbar region. We don't need to use 5-9 or XS because according to the CCI edits, those two codes can be performed in the same anatomic site, and they were both in the lumbar. Now with certain United Healthcare, Anthem, Medicare, you need to use the GP. Same scenario in patient number 4. This is not Anthem or United Healthcare. They may not require the GP, so it goes out without any modifiers at all. Look at that, 98940, lumbar, 97110, therapeutic exercises, lumbar. This is an Aetna, Cigna. They don't typically require the GP. In this case, it could be done in the same anatomic site. So you don't need modifiers at all. Now, some of you might be saying, well, we bill that and we get denied. I'll tell you what to do in a few minutes regarding those. Patient number 5, I'm going to throw in a Medicare patient here. Medicare Part B, do a chiropractic adjustment to 3 regions. There's your AT modifier, 98941 for active treatment. This is a patient that has not reached wellness or maintenance. And let's say you also do mechanical traction on a Medicare Part B patient. Medicare Part B doesn't pay for mechanical traction. Some of you are saying, why would we bill that? Well, maybe Mr. Jones has maybe Mr. Jones's wife works and she's a teacher and she has a good insurance company that's going to be a secondary to Medicare and they'll pick up the traction. So it would go to Medicare first with the GP and the GY. Now, I have a few more scenarios, but before I get to that, let me explain how the National Correct Coding Initiative edits look like and how they work. To begin with, you can Google, if you want to get the full spreadsheet of all the CCI edits, it's free. Go online, Google CCI edits, and you'll get them. You'll download a spreadsheet. Be careful. The spreadsheet has over 600,000 lines. Those of you that are familiar with Excel spreadsheets, they're usually not that big. 600,000, over 500,000 lines in this spreadsheet. I plucked out about 25 right here on your screen. I don't know, about 15 or 20 or 25 on your screen. These are the ones that relate specifically to chiropractic. So if you look at the CCI edits and you look under column 1, there's usually 3 columns, column 1, column 2, and the CCI modifiers, which have nothing to do with the 2-digit modifiers we were referring to. So let's look at column 1. You see 98940, and then column 2 says 97140, and then the CCI modifier of 1. What does that mean? That means it's allowed. If it's allowed, now you have to put the 59 modifier on there or the XS to show that it's separate and distinct in order for the claim to get processed. Now look at the third one down, 97140. That's manual therapy. And then in column 2, it says massage therapy. That's 97124. Look at the modifier there, 0. That means not allowed. So if you are billing a health plan for massage therapy and manual therapy, it doesn't matter even if it's on separate sites. If it's on the same day, there's no payment because the CCI edits say 0, not allowed. So there's a whole bunch here, and some of them are not applicable, but they're payable. For example, 97110, you see the 6th one down, on the same day as an exam, that should get paid. The CCI edits are not applicable. And there's others here that are applicable. And then there are some that you're getting denied and the health plan has not done their homework. I'll give you an example. Look at the 4th one down, 97012, that's mechanical traction. And then 97140, manual therapy, that includes manual traction. So some health plans go, oh, we're not going to pay for both mechanical traction and manual traction on the same day. Well, the CCI edits allow it. It has modifier 1. So in that case, you just have to use certain modifiers and do it in separate anatomic sites. Same thing with attended stim and unattended stim, the 3rd one from the bottom. You can do that. Some plans are denying that incorrectly. And then there's some situations like, look at down at the bottom, manual therapy and therapeutic exercises on the same day. There's no CCI edit on it, so it's okay. You can do it. All right. Patient number 6, you do an adjustment to the cervical region. You do mechanical traction on the cervical. Now we're talking about an Anthem, United Healthcare, Medicare. So, okay, they want the GP. And then you're also doing manual therapy on the lumbar region. So then we're going to use the XS or the 59, depending upon what the plan wants and the GP. Patient number 7, adjust the cervical, shoulder extremity adjustment, unattended stim to the cervical, manual therapy lumbar. There you go. The manual therapy in this case gets a modifier. The others don't. If it's a typical Aetna or Cigna. Eventually, I think all health plans are going to want the GP. or the excess, 5-9. Patient 8, adjust cervical. You do manual therapy to the lumbar. There's the excess and the GP. And then you also do therapeutic activities. There's a new code, therapeutic activities. In that case, according to the CCI edits, you have to use the excess on both, the GP on both, or the 5-9, depending upon the plan. Patient number 9, 98940, adjust cervical, a lumbar. Oh, look at that, 97150. Do any of you have an open therapy bay where two or more patients, many patients are all exercising in an open area, open adjusting area? That's group therapy, 97150. And then last patient, number 10, adjustment. And then we have unattended stim and attended stim on the same day. It should get processed properly. All right, now we're going to move on to modifier AT. This is a Medicare modifier. It stands for active treatment. Active treatment. Under the chiropractic guidelines, please read them. They're online. They're easy to get. Read the chiropractic guidelines. And in your opinion, after you read the Medicare guidelines on your Medicare Part B patients, you feel this is active treatment, submit your chiropractic adjustment codes with AT. Once the patient gets to a point where they've stabilized, it's either wellness or maintenance, if you feel that wellness and maintenance is something you want to do, not every chiropractor offers their patients maintenance. I'd say 80% of the doctors we work with are encouraging patients to come in after the pain is gone for wellness and maintenance. About 20% of the doctors I work with, they don't care about maintenance. They don't really address that. If you're one of the 80% that want patients to continue to come in after they've stabilized, after there's no more insurance benefit, then you may want to offer them wellness maintenance. Medicare Part B patient says, yes, Dr. Kotlar, I would like to continue to come in, even though I know Medicare is not going to cover it because I've reached wellness maintenance. So at that point, you have to give the patient the ABN form, which we're not going to get into the ABN form at all today. We're running out of time. That's a whole separate webinar. So the ABN form is given to the patient. And let's say the patient checks option 2, then you don't have to bill. If they check option 1, then there you go. There's the example on your screen. You'd have to submit the claim to Medicare just for denial purposes. I know that sounds a little strange, right? To bill an insurance company just to get denied properly. Well, you'd have to do that in this case by using the GA modifier. And then the GY is used for all non-payable services. GY is not used on spinal adjustment codes. It's used on all other services besides spinal adjustments like x-rays, extremities, modalities, therapeutic procedures, exams, and re-exams. Never use GY on maintenance chiropractic adjustments. So there's a couple of examples there. Exam, 25 and GY, mechanical traction, GP and GY. Staff members listening to this, and doctors, if you don't have an outside billing person helping you out, analyze your EOBs very thoroughly. They will oftentimes tell you if the insurance company knows what they're doing. For example, there's one particular health plan that keeps denying my clients on the 97012, stating that it has a modifier exception and the documentation doesn't meet it, but it did. And then there's another one here regarding the 5-9, and it says this procedure is inconsistent with the modifier used. So do your best to get paid the first time. But if for some reason your claim is getting denied, step 1 is to call the health plan. Well, contact the health plan either online, email, or telephone. If you get a denial that you feel is inappropriate, what I've taught you about these modifiers is, knowledge is power. Now you know what these modifiers mean and when they should be used. And if you do it properly, your claim should get processed properly. But there are some health plans that I don't know if they have glitches in their system or what's going on, but they are denying claims that are sent in properly. So for some reason you get a denial and you feel you've done it right, step 1, contact the health plan, either online, telephone, email, and request a solution. If you receive corrected claim instructions and it works, great. No news is good news. Let's assume you can't get a straight answer and you keep getting denied improperly and you can't get anyone at the health plan to help you out. Well, in this case, they're not following the rules. They're violating HIPAA by not following the CPT code set. Next, demand to speak to a supervisor and show them how the claims are being processed incorrectly. They must take action, especially if you're a participating provider. If that doesn't work, notify your patients. This could be causing a financial burden on them. Patients should contact the health plan and demand an answer to the situation. Maybe you want to file a formal complaint with the state insurance commissioner. If that doesn't work, maybe you want to contact your own attorney and send a letter to the health plan demanding a solution. There's a lot of things you can do. So just a couple of other things I want to go over before we end or open it up to more questions and answers is billing and coding compliance. There's two types of compliance, billing and coding and HIPAA. HIPAA, you should know, that's to protect patient health information like their credit card number, their address, their phone number. You want to protect their information. You have to have a secure, encrypted site. You want to make sure nobody could access your patient information. If they can, this can cause a HIPAA breach. It can cause malware. It can cause thousands and thousands of dollars of breach payments. So you want to protect patient information, get a good quality HIPAA program in place. The purpose of billing and coding or Medicare OIG compliance is to prevent billing and coding errors. So I have a question for all of you. How do you provide proof? If the insurance police came knocking on your door, how would you be able to provide proof that you make formal efforts to prevent billing and coding errors? All health plans want you to do that. So I'm going to show you how to put together a basic billing and coding policy and procedure manual. Start doing it on your own. If you can't figure it out, then go ask someone. You don't have to use us if you don't want to. We think you should, but that's up to you. So I'm going to show you to start. I'd rather you start doing it on your own. So here we have a policy on you're supposed to be looking at your own records and scoring yourself. You're supposed to do a complete, thorough review of your own records. You are required to put together a billing coding manual that includes training, staff training, 3 hours per year. Those of you listening to this, if you have a billing and coding compliance manual, you're getting 1 hour today. Put that in your compliance manual, put it in an Excel spreadsheet, and there's proof. You got 1 hour out of the way. You only need 3 for the whole year. Exclusions, yes, you're supposed to do background checks, especially on any employee. I'm not talking only about the doctor. Even if you have a front desk assistant that's dealing with Medicare Part B patients, maybe taking co-pays over the counter or entering CPT codes into your system, your front desk CA would also need to have his or her name put into the exclusions list. That's exclusions.oig.hhs.gov. Put your name in there. So yes, background checks are important. If this doctor wanted to work in your office, you couldn't hire him. He's excluded from the Medicare program. His license was suspended. Here's another chiropractor. She's kicked out of the Medicare program. You can't have her see your Medicare patients. Why? She defaulted on her student loan. She didn't pay her student loan. If you're a chiropractor that didn't pay your student loan, you're not allowed to see Medicare patients. You're not allowed to see any federally funded patients. Medicare, Medicaid, TRICARE, Railroad, Swiss Chip, veterans. Can't see patients if you are thrown out of the federal program. This is what you want. You want to put your name in and it comes up, no results found. This is what you want, print it out, put it in your manual. And in the manual, there's different policies. Like, what's your policy on free exams, free x-rays, free adjustments? This chiropractor got in big trouble for offering free electrical stim. He had to pay an $80,000 fine. Do you offer discounts? It's okay to offer a discount. How much are you offering? There are certain limits. What about deductibles and co-pays and co-insurance? Is it okay to waive co-pays, co-insurance, and deductibles? The answer is Maybe. It depends on the situation. There are a few situations where it's okay. It's the routine waiver that's not okay. Saying all the teachers that come into my office, I'm not going to collect the copay. Or, Wells Fargo Bank, they have a huge building next to my office and their insurance is really good. I'm going to tell all these Wells Fargo Bank people, come in. You don't have to pay me anything. Your insurance in full. See, that's not okay. There is a statute. It's called the patient inducement statute. And you're violating it if you are providing payment or remuneration for waivers. Waivers of coinsurance and deductibles is looked as though it's a gift to a patient. This chiropractor, client of mine for years, I've been telling him, collect copays, collect the deductibles. Wasn't doing it. Gets this letter from Cigna. We want to see copies of patient billing and collection ledgers. We want to see documents that show when bills were sent to the patient, if any, and how much was paid by the patient. These patients weren't paying anything. What is he going to do? Big trouble. Here's another doctor that I know who also wasn't listening, gets a letter. Dear doctor, after contacting some of your patients, it has come to our attention that you routinely waive all patient responsibility. And he had to fill out a questionnaire. The first question was, do you waive copays and coinsurance? Yes or no? If yes, he had to fill out more information. And there was a whole bunch of other questions. If you do waive copays and coinsurance, why? So you want to read your EOBs properly to prevent errors. There's a lot of columns, doctors, staff members, there's the billed amount, allowed amount, deductible, copay, coinsurance, adjustment write-offs, and then finally, it's what you were paid. You want to become a 10th degree black belt in reading EOBs. So prevention is the key. Just a few closing comments, Valerie, then I'm done. As far as what we do here at Target Coding, besides these webinar presentations, we offer products and services and compliance programs. We have a book. This is a book that I've written. Many of you own this book. It's a book on the best codes to improve reimbursement. It provides really good detailed information on how to pair your codes, like pairing peanut butter and chocolate or food and wine. It'll prevent denials. It'll make your claims go through the system smoother. So chapter 1 talks to you about pairing your codes. Chapter 2 shows you the codes that pay the most visits. I break it down into long-term treatment codes, short-term, moderate term. And then chapter 3 is a whole bunch of cheat sheets. And then it also gives you a whole bunch of diagnosis codes and the clinical rationale. For example, if you're going to diagnose a patient with sciatica, you should do straight leg raise. If you're going to diagnose a patient with cervical radiculopathy, it's a good idea to do some Jackson compression. So I have some good clinical stuff in there. And we also offer memberships at Target Coding. We have 4 levels. They're here. You can check them out on the website. Level 1, unlimited Q&A, questions answered within 24 to 48 hours, access to all of our webinars, including our CA boot camps. Level 2 is where you get access to our videos and forms. Level 3, we do a comprehensive review of your notes, your fees, your codes, your forms, unlimited training. You also, level 3 includes a billing and coding policy and procedure manual. Level 4 are for integrated practices. So I just wanted to share a couple. Also, we do billing. We've had a request over the last 2 years for us to do billing. So now Target Coding does billing. You want to outsource it to us, let us know. Here are our CA boot camps. Very popular forms. We also do credentialing. Those of you that need a PTAN, maybe you're getting busy, you want to bring on an associate chiropractor. That associate needs a Medicare number, no problem. Within 2 weeks, we could probably get you a Medicare PTAN number, and we do credentialing. We also offer compliance programs. All righty, so I'm ready for questions and answers.
There's still a few questions here. Somebody wants to make sure on the code, if you had a code 97140-59, do you add the GP code? So it's 97140-59 GP, or do you drop the 59?
I don't usually like to answer a question with a question, but I have to. 97140, why, if you do it in a separate region, why wouldn't you use the 59? So that's, you have to use the 59. Now, if you're saying, hey, our experience has been, we don't use the 59 and the claims are getting paid, I would be very careful with that, because if there's an audit and you're doing the adjustment in the same region as the manual therapy, you may have to give the money back. So yeah, 9714059. Now, if the claim gets denied and you're not sure why, contact them. That plan probably has switched to the XS modifier. If you can't get a straight answer from them, I gave you those, 5 or 6 steps to follow if you can't get a solution directly from the health plan.
So Dr. Kotler, can I ask a follow-up question to that? So in some plans, they might switch from 59 to XS.
Yeah, some plans like Anthem on April 1st, they decided to switch from 59 to, I'm sorry, they decided to add the GP. Some insurance companies are still paying with the 59. Some want the XS. Anthem wants the XS. It's right in their policy.
So GP wouldn't replace 59, but XS might.
GP has nothing to do with 59 or XS.
Okay, and then the next one was a question that we had talked about before the webinar started. So claims are not processed because they're telling us that EIN and NPI do not match, which is not true. This is with BCBS. Do you know anything about this and what we should do? It's been going on since March.
Yeah, it's a shame. It's like calling an insurance company and saying, how much is 2 + 2? And you tell them it's 4 and they go, no, it isn't. And you ask them why, and they go, we're not telling you. It's a shame. The claims there's a glitch in their system. The proper way to do it is whoever touches the patient, the individual MPI number goes in 24J. That's typical. Typical standard is the group NPI is in 33A and 32A. That's standard. That's the way it should go. If it doesn't work, then ask them what to do. If they can't tell you, now the frustration starts to occur and you have staff members ripping their hair out, going crazy. It's a shame.
And a follow-up to that, Dr. Kotler, what if they don't have a practice MPI number? What if it's just like a single doctor with a personal MPI number, but not a practice MPI number?
Well, there's individual MPI number and there's group MPI numbers. So typically a group MPI is created. And if that works, fine. To me, you got to go with what works. So if the doctor is using a group NPI and that's the reason why the claims are getting denied, and the doctor contacts the health plan and can't get a straight answer, so now the doctor has to start guessing and gambling. All right, you want to try? Now, to me, this is like looking into a crystal ball. You just want to try doing things? Yeah, then switch to your individual MPI, see if that works. And that could work for a while, and then they start denying that, and then you go back to the group. So it'll all get worked out. Right now, there's some glitches going on with the health plans regarding this NPI situation, and the EIN is the tax ID number. That's different than NPI. Tax ID number is in box 25. Now, if the doctor's tax ID number is causing the problem, and you can't get a straight answer from the health plan how to fix it, then try using your social security number. I'm just throwing things out without knowing for sure, and that's dangerous, but I'm just giving you a couple of things that may work. But the most important thing is contact the health plan. Get the name of the person you're speaking to. Get the reference number and hold on to all that stuff, because eventually you'll get paid, and you might get paid with interest. and maybe there'll be a class action lawsuit occurring because of all these denials. I'm not sure, but the best thing to do is just write down all your conversations with the health plans, and you'll be able to prove to them that you're doing your due diligence to just get the claim processed. This shouldn't be such a big deal. Patient comes in, you give them a good adjustment, you submit the claim, you should get paid. There shouldn't be so many problems. It'll all get worked out soon.
All right, I've got one more. Let's see. All our 97110s got denied without GP. What is the best way to ask for the money after correction?
Well, that's where the doctor messed up. The doctor didn't bill with the GP. That's why the claims get denied. So resubmit with the GP, and that should be the answer to the problem.
Okay. Any other questions for Dr. Kotlar? All right, thank you so much, Dr. Kotlar. We appreciate all this great information that you gave us today. And for those listening, if you want to review this again, we're going to be putting it up on our YouTube channel. Just go to YouTube and search for Georgia Chiropractic Association and you'll find the video. Thank you again, Dr. Kotlar. Do you have any final words?
No, if anybody has any questions after we hang up, feel free to email info@targetcoding.com and we can set up a free consultation. I offer free consultations on the topics that we spoke about, or anything to do with chiropractic billing, coding, documentation, Medicare, HIPAA. Set up a free consultation, send an email to info@targetcoding.com. And what we do is we send you an email back and you click a link and you'll see my calendar. Pick a day, pick a time, and we'll get together and we'll chat. So I offer free consultations to anyone listening to this. And again, thank you for having me.
Thank you. Have a great day. Thanks, everybody.